All right, well, hello everyone, and good evening. I'd like to welcome any new participants we have joining us tonight, as well as welcome back anyone who's joined us in the past. Before I introduce myself, I'd like to bring to your attention the first of 3 polls that you can find on your screen. If you could just click on the answer or response that best applies to you, and just keep listening. I'm going to keep discussing what's going to happen tonight. So it's my pleasure to welcome you all to tonight's virtual Grand Rounds presented by the American Academy of Developmental Medicine and Dentistry. My name is Michael Tarr, and I am a second-year medical student at New York Medical College, and I am the AADMD Virtual Grand Rounds facilitator. So I'm just going to look at the first poll real quick. So the question is, which professional role do you represent? And so far we have 20% are representing administration, 3% are students, 13% of people are working in medicine, 3% in dentistry, and 59% other. And I'll share that with you so you can see it for yourself as well. So for a second poll, which is now on your screen. So AADMD Virtual Grand Rounds sessions seek to create a space for mentorship and exchange of knowledge and experiences between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Rounds session is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. So I'll just close this poll real quick. So in our second poll, which asks in which stage of your career are you in, we have 4% are in the pre-health professional training, 28% are health professional training, 0% are in their residency, 64% are currently practicing, and 4% have retired from practice. So just one more poll. So at the end of this session, we'll send you a link to a quick survey we've made, and it shouldn't take more than 5 minutes, but it's very important for us that you do fill it out because the feedback we receive through this survey allows us to improve the virtual Grand Rounds experience and also to hear what future presentations you would like to have us organize. Once I've finished introducing the presenters, I will paste the link to the survey into the chat box that you all have available to you. So I'm going to close this last poll, share it with you. So our last poll asks, what do you hope to gain from this webinar? So 14% said they'd like to learn foundational healthcare concepts for individuals with intellectual and developmental disabilities. 0% said networking. 46% said gain interprofessional perspectives on healthcare for individuals with IDD. 39% said gain pearls from complex and challenging clinical cases, and 0% said CE credits. So that being said, I will introduce tonight's presenters. Tonight we have Dr. Carrie Boyd and Dr. Amanda Ritzma. Dr. Carrie Boyd has dedicated her career to the field of developmental disabilities across the lifespan, working with clients who have autism for over 15 years. Dr. Boyd is an associate clinical professor at the Department of Psychiatry and Behavioral Neuroscience at McMaster University and works as a developmental psychiatrist at McMaster's Children's Hospital and Bethesda Services. She also serves as Bethesda's Chief Clinical Officer. Dr. Amanda Ritzman is a psychiatry resident at McMaster University in Ontario. She has a special interest in intellectual disability and medical education. Her research interests include holistic care and how it can be integrated into the medical approach. Before I give the floor to our presenters, I'd like to remind all of you that during the lecture, if you have any questions or want something clarified, please use the question box or the chat box. At the end of the session, I will relay the questions to our presenters, and they will discuss the answers with you all. With that being said, I'd like to give the floor to Dr. Boyd and Dr. Ritsma.
Thank you very much, Mike, and we're very delighted to be doing this. I met many some of you at the conference in Los Angeles, and so love the idea of the virtual academic rounds. What we want to do is, well, hopefully something that appeals to anyone who logged in. This should appeal to a broad audience. We will have some foundational principles, but also be going over some case examples about how to deal with complexity. We also are very thrilled that at the Bethesda I work at, which is in Canada, we also have a very talented group of people called Momentum Choir and Spotlight Drama. And we're going to be ending with a very original song, actually 2 videos and 2 songs that are teaching videos that we hope reinforce the things we're going to be talking about tonight. So Dr. Ritsma and I are first of all going to lay some foundational principles, including where we live. We live in the Hamilton-Niagara region on the Canada side of the border. And those of you in the States, I think we do have a much nicer falls, but you have a great country too. So we're presenting from the Hamilton-Niagara region in Canada. And what we want to do is talk about what ended up being my chosen career, and that is working with people who have a dual diagnosis. So I'm a physician who studied as a psychiatrist and fell into the field of developmental disabilities, and then fell in love with the population, the teams that I get to work with, and also learn to embrace ambiguity. So dual diagnosis has a definition. By the definition we're going to use in the field of developmental disabilities, it means people who have a developmental disability and a mental health problem. As you know, there are differences in how people define things. Here, developmental disability would be someone who would have various cognitive and adaptive challenges onsetting before age 18. And mental health problems could be anything from a behavioral problem to a psychiatric disorder or mental illness. Now, part of the problem that we're depicting in this slide is, even though we call it dual diagnosis, very often it is not just 2 things. There are multiple things that are going on, and diagnoses can be a little fuzzy. They can be sometimes difficult to make with people who can't report symptoms. And so we learn to live with this ambiguity, and we certainly want to give you the impression that this is possible. Working with people who present with complex, challenging behaviors where things aren't always clear, but we can get the picture, in, particularly if we look at things in a biopsychosocial way. So just a few key points for you. In dual diagnosis, often the presentation is kind of atypical. If someone has a medical or mental health problem, they often present with a behavior. And it may be self-injury or aggression, or it may be a behavior that's more like a negative behavior of withdrawing. Also, we want to make the point that there's often more than one variable, more than one problem that's going on. And often when the problems hang together, they can be synergistic or snowball, so to speak, into a crisis. Certain of the interventions that we may offered to help could in fact compound the problems, and in particular we think about psychiatric or psychotropic medications. So we'll talk about that today. Also, just to get this idea that people who are suffering with a dual diagnosis, it really is interfering with their development, relationships, and quality of life. So the whole point of this presentation is, how can we get the picture when someone is presenting with a complex behavioral profile and things aren't immediately clear? We've had a chance to work with a number of people, actually, well, hundreds, maybe even thousands over the years, of children and adults who have a developmental disability. And all would have a story to tell if they could tell it. And I can just assure you that the results are very rewarding. And I think if you've been in the autism world in particular, you'll recognize the kind of logo or emblem of puzzle pieces. The idea being that if only we could have enough knowledge, enough puzzle pieces, we could put things together and create more answers. I thought we might just upgrade this analogy a little bit because it's not always easy to do, particularly when we're talking about the brain and people's lives. And we all know, any of us who have been working in this field, that there's no such thing as a quick developing snapshot. There are no Polaroid pictures where you just shoot, snap, and the picture develops within 3 to 5 minutes. It's actually more like a pixelated picture where we need enough information to have enough clarity to be able to form hypotheses and hopefully work as a team to do something to help. And when you're looking at a picture that's pixelated, hopefully when you get the information, it actually presents with something that is true to reality. This is not true to reality. This is a gratuitous picture of my children, and they're forbidden to go over Niagara Falls in a barrel. So what we hope to do with the biopsychosocial model is get more accurate content when we're getting to know people and help with the process of our clinical assessment. And the biopsychosocial model, we'll just tease it apart. Really, we're looking at the biomedical or the physical factors that influences someone's health and well-being. Also, the psyche or the psychological variables that affect a person's development, and also the social or systemic variables. And really what we need to do is be open-minded when we meet with someone with a dual diagnosis. We need to be able to explore thoroughly, be more comprehensive as we're gathering biomedical data, or learning about the person's subjective experience or the context that plays a vital role often in why they're presenting the way they're presenting. Also with the biopsychosocial model, it helps us with the process of our interactions with people. Really, it lends itself well to person-centered interviewing, putting the person's needs at the forefront, also person-centered interventions. And when we're looking at the biopsychosocial model, there's a recognition that often with multiple things affecting the person's presentation, we need multimodal interventions. And that really requires teamwork. Teamwork with the person at the center, caregivers' perspectives being included, and interdisciplinary teams. It really is the standard of practice and how we can get the job done more satisfactorily. And even though there are no quick fixes, progression can certainly happen in a positive way when we work as a team. So, complex behaviors. I'm sure any of you who have worked in this field or lived among people who have developmental disabilities recognize that things can get complex. So we just would like to call upon you to think about some of the scenarios, some of the cases, some of the people that you may have met along the way. And think about particularly the ones that were complicated, where a simple intervention didn't really do the trick. And recognize how distressing this is for people and how, frankly, distressing it can be for us. And our goal is really to improve people's health, their functioning, relationships, and quality of life. So I'm going to give you a quick illustration of what I'm going to call BioPsychoSocial Grid training. And what we're doing is looking at the biological variables, psychological variables, and social variables that have impacted the person in their presentation. You'll also see 4 P's along the side. And the first P stands for predisposing variables. That is really the background for why things are occurring as they are. And then the PREC is the precipitating variables. What actually got this problem going? What triggered it? And then the PERP is perpetuating variables, and then finally protective variables, the things that we need to take into account that will help us to come up with some solutions to make things better. So I'm just going to give you a simple example. I'm from Canada, and we have blackberries here. I'm sure you do in the States and other parts of the world as well. But what we're going to do is talk about a hypothetical woman who's in her late middle age who is throwing her BlackBerry repeatedly. Now, this is not someone with a developmental disability. This is someone who is a professional throwing a BlackBerry. Now, why would this happen? Let's look at the biopsychosocial variables that may be influencing this. Okay. So first of all, biological predisposing variables, maybe there's something genetic about technology in this woman. And we won't go out on a limb to say that it has something to do with 2 X chromosomes, but there may be some copy number variations that add up to someone not being good at technology, which led to really a psychological deep-seated aversion to technology. And socially, a lot of these behaviors got reinforced in childhood. Every time she would throw her VTech child toys and broke them, parents would go out and buy a bigger and better one. And as a psychiatrist, I warn you not always to blame the parents, but it could also be part of the backdrop that's important, the early childhood experiences. Next, the precipitating variables. Why fling the BlackBerry? Well, first of all, we all have a stress response, and when this woman got her BlackBerry, it was alarming to her when the phone would ring and all kinds of texts and emails and phone calls were coming through. And you talk about the fight or flight response, we're going to add in the fight, flight, or fling response, flinging the BlackBerry. And this person was alarmed by the certain triggers that would come across her BlackBerry. And it became clear that people weren't using proper BlackBerry or email etiquette, and there was cyber conflict going on. Hence, a lot of stress. What kept the problem going? Because the BlackBerry kept getting flung. Well, interrupted sleep. She didn't know how to turn off the device so she wasn't interrupted with every email that came through at night. A lot of negative cognitions were happening psychologically, and socially started to notice that some of her friends and colleagues had iPhones and Androids, which she thought were far superior, and she became covetous. Next, let's talk about protective factors. Basically, this woman was healthy, wanted to be reasonable psychologically, and socially she had colleagues who were willing to help her to turn off the BlackBerry at night and would not buy in to her maladaptive behavior by buying her an iPhone or an Android. Okay, you get the picture of the biopsychosocial grid. Let's just go over some of the factors that are important for people with developmental disabilities. Predisposing biological variables often include the reason for the developmental disability or the intellectual disability. Sometimes there is a known cause, and when it's genetic, it's particularly helpful. Down syndrome, the most common cause, but there are other genetic syndromes where there are lots of good information for us about the kind of phenotypes that people can present with. People with developmental disabilities may also have physical problems like scoliosis or cerebral palsy. Also, there can be medical factors that complicate things for people with developmental disabilities. Neurological conditions like epilepsy. There can also be psychiatric problems that can be diagnosed, and also medications. And again, psychiatrists and physicians trying to help may prescribe medications that can make things worse with side effects. And so we will touch on that in today's presentation. Next, we want to talk about the precipitating variables. Why do problem behaviors start? And usually, there's some kind of biological stressor that's going on. And it may be that there was a sudden onset of an illness. Often people with dual diagnosis have undiagnosed and untreated physical problems such as pain or infections. There may also be an injury that is reported or not well communicated and shows up as a challenging behavior. There may also be psychiatric problems like depression or less frequently psychosis. Also, again, some of the treatments can make things better, but some of them can also make things worse and cause side effects. Sleep disturbance is a common precipitating variable for people acting out in distressed ways. Now, let's look at the things that can keep the problems going, the biological perpetuating factors. Why do behaviors keep happening? Often there are medical problems that aren't properly identified or fully treated. There may be neurological problems, such as seizures, or maybe there are hormonal variables, such as happen with puberty or perimenopause. We also look at people's mental health being compromised, particularly by chronic stress. Side effects to medication need to be mentioned again, and also chronic sleep disturbance. We're learning more and more about how that can perpetuate mental and physical health problems. And finally, protective factors. Many people are very physiologically resilient. Good health is a protective factor. Recognizing some of the medical disorders or genetic conditions and treating them appropriately is certainly protective. And having a positive response to interventions and the use of multi- and interdisciplinary healthcare teams. So that's the rundown of the biological 4 Ps. Now let's look at the psychological 4 Ps. First of all, predisposing variables. There's a brilliant literature on temperament. We know that there are just ways that people are born, and if you boil down the temperament literature, there are people with easy temperaments, difficult temperaments, and slow to warm up temperaments. And sometimes we're able to tap into what they were like from a young age. It's also very helpful when we know their cognitive profile with their strengths and challenges, how they communicate. Everybody communicates, whether with words or not, and effects of things like neglect, abuse, and trauma. And just knowing people's perceptions and beliefs is very important. Psychological stress can be a real precipitating reason why people present with challenging behaviors. Fear, anxiety, grief, frustration, and rage can all be psychological experiences that show up as challenging behaviors. What keeps the psychological challenges going? Stress, either chronic stress or acute stress. There are also patterns of thinking, reacting, and behaving. Not being understood can really make people extremely stressed in an ongoing way. Loneliness, purposelessness, lack of stimulation or overstimulation, exhaustion, and depression or dysthymia. Protective variables. I'm sure many of you will recognize how very resilient many of our patients or clients are. If we can engage them in therapeutic relationships or in social relationships, that can be a real protective factor, especially engaging them in health-promoting behaviors, problem solving, and just these intangible, unmeasurable things of faith, hope, and love. Socially, we want to look at some of the predisposing variables as well, and sometimes we get the privilege of knowing people's family backgrounds or their cultural backgrounds, their experiences in education. Sometimes they're good, sometimes they're rather traumatic. Teasing and bullying is very common, and we know that there are other very traumatic events that can happen for people. We're very isolated, and some people grow up in impoverished conditions. We also know that there are social precipitants for behavioral presentations. Think about our own lives and those we love. Conflict in relationships can precipitate crises or stress. Losses can be very common with people with developmental disabilities. People come and go. Conflict, abuse, and bullying are much more prevalent and can precipitate the reason for people's challenging behaviors. And we also know there's social or indirect aggression and bullying that can happen on the internet or particularly among females. And then I write down resources, because often there's a lack of resources. Perpetuating variables, again, I say resources. People all have hopes and dreams, and yet there's often not enough money or support to do it. Relationships can be a source of stress, and also unresponsive, unreceptive settings. But let's look at the final flip side of positive, protective social variables. Receptive or responsive communities, developing rapport or relationships, working as teams, and meaningful engagements. So hopefully you get the picture of this grid and how it can be helpful for real people in your practice. So what I'm going to do now is just talk about the BioPsychoSocial Grid with one of the individuals that I first met in my residency training. She chose her own pseudonym. Her name is Sandy. As her mother explained, she developed very typically as a young child. In fact, she wouldn't know that anything was wrong until her mid-teenage years. I met Sandy when I was a first psychiatry resident, one of my first patients when she was 15 years old. I met her again at age 20 with an interdisciplinary team that specializes in dual diagnosis. And then I caught up with her in her 30s, visiting the family to get their permission to tell this story. And I'm pleased to tell you that tonight Dr. Amanda Ritzman and I visited their home. She just turned 41, and they are pleased for us to share this presentation with you. So let's learn from her story. Complex presentation, very distressed at age 13. At age 15, she was yelling, vomiting profusely, and wasn't functioning at all at school or at home. We learned about her biological predisposing variables. She had early feeding problems and a cleft palate. She had cyclic vomiting with frequent medical infections from quite a young age. Psychologically, she had communication difficulties. She spoke with a very nasal voice, and it was hard for people to understand her. She had a lot of frustration and anxiety. She was labeled a slow learner and put in special education classrooms. Socially, she was teased a lot and sometimes bullied. The family felt very stressed and felt a lack of supports, very isolated, especially as she had to undergo various medical investigations for her vomiting. I met her at age 15, and she was exhibiting severe vomiting on the psychiatric ward. She was becoming dehydrated and had a very psychotic presentation. She had numerous biological investigations, yet nothing showed up. We even did clinical genetics in the early 1980s, and that showed no genetic findings. Psychologically, she was distraught. She exhibited paranoid ideation and a lot of confusion about what was going on. She required 3 psychiatric admissions and did not respond well to psychiatric medications. The family were very uncertain about what was going on and dissatisfied with services, whether it was medical or psychiatric services, and they were extremely stressed. She was discharged from hospital on medications to a group home. And unfortunately, when I caught up with her in the 20s on the dual diagnosis team, the stomach problems persisted. She had constipation and vomiting. She was clearly depressed and anxious, and psychosis had worsened, hearing voices with clear paranoid delusions. She was treated with antipsychotics, but they did not result in complete remission of her symptoms. We did, however, treat her with an SSRI, selective serotonin reuptake inhibitor, and her mood and anxiety got better, as did her vomiting. We then sent her for repeat genetic testing, and lo and behold, 22q11.2 deletion syndrome was identified. That gave a lot of answers about why she had the learning problems, why she had the stomach gastrointestinal problems, and why the early psychosis. So we started to engage in more specific interventions, including psychological interventions. She had a lot of speech-language problems, so we got a speech-language therapist involved. we realized that the antipsychotics were only partly effective, so she got sent to a clozapine clinic for more specialized treatment. And we also engaged her with a behaviorist and psychologist. We engaged in truly interdisciplinary care. The family were very relieved to getting the genetic syndrome identified and joined up with a research project with Dr. Ann Bassett, world-renowned researcher in Toronto. They were also very troubled by the poor fit of Sandy living in her current group home. She also had intimacy-related concerns and required genetic counseling, so she would learn more about her autosomally dominant transmitted deletion syndrome. They then worked toward getting better care and moved her back into the family home. When I caught up with them in their 30s, they were pleased to report, and these are protective variables, pleased to report that she was relatively healthy and had an absence of 22q deletion syndrome medical features. Her medications were much more efficacious, including clozapine, and she remained on selective serotonin reuptake inhibitors for depression and anxiety. They used the Health Watch guidelines, which are referenced here. The website is Surrey Place. Psychologically, she now described herself as content and at peace. Her parents described her as loving, caring, and very funny. Best laugh that I've heard in a long time. The family were also more cohesive, even the extended family. They all felt a lot more secure with the medical issues dealt with, and they believed they had good clinical care. And they all wanted to give back and help others. Hence, they allowed for this presentation, which we showed them tonight. This is a picture of them earlier this evening. Now Sandy in her 40s, and they all wanted to say hello to you and help, and hope this will give you a better picture. Now I'm going to hand it over to Dr. Amanda Ritzman, who's going to show you how this BioPsychoSocial Grid can help you to formulate interventions.
So we wanted to introduce another case, and this isn't actually a specific case like Sandy's that we encountered within the clinical setting. It's an amalgamation of many of the patients that we have that come to the dual diagnosis clinic and how they may present, and some of the problems and issues that come up quite frequently and how they can be managed. So we're going to meet Zane. He's a 25-year-old diagnosed with Fragile X syndrome at the age of 15. As many of you will notice, that's actually quite a late presentation into the healthcare system. He was referred to a pediatrician who recognized that he had traits of an autism spectrum disorder. He was having quite marked sleep disturbances, and he also had impulsivity and hyperactivity, later diagnosed as ADHD, or attention deficit hyperactivity disorder. From this appointment, he was prescribed a stimulant to help with his ADHD and was given low-dose risperidone to help with many of his sleep disturbances. When Zane was diagnosed, the family was tested. Because as you know, Fragile X tends to run in families, and it's the number one inherited cause of intellectual disability. His mom was found to be a carrier. His brother was actually diagnosed with Fragile X syndrome, and his sister had negative results. His sister was 7 at this time. Zane's father left shortly after his sister was born and therefore was not tested. So Zane's mother reported feeling incredibly overwhelmed for about 7 years, and as you'll note, this lines up with the birth of the younger sister. Zane's mother was a carrier, so this comes with its own concerns and issues, a lot of the times with learning disabilities, which can be very overwhelming having 2 children who need special needs as well as a young infant at home. She declared a crisis after Zane left high school at the age of 21. In Ontario, I'm not sure how it works in the countries that we are being attended from. Most individuals are eligible to be in school until the age of 21, but at that point, they do have to leave whether they've achieved their diploma or not. It was very difficult to find affordable programming for his activity level and his short attention span. And this is, again, quite the reality, especially in Ontario, for adults to find programs to engage themselves in during the day. Zane became agitated at his placements, and this became quite a problem because he was struggling with things to do during the day. One of the variables that we think contributed to some of this agitation were his sensory needs. And as you can see, they're quite complex. He gets overstimulated in these chaotic settings. The programming that he's in brings individuals with all sorts of needs, and that, again, can be an overstimulating environment. Yet he can be understimulated without meaningful activities. He's transitioned from school, where he has a structured day, to being at home with limited programming. He does not use words to talk, but he can signal his distress by yelling and engaging in self-injurious behavior, most commonly biting his wrists. At the age of 22, these behaviors started to worsen, and he was slapping his head, he was starting to hit others, and this was quite traumatizing for his family, especially his siblings. The crisis response at that time was to place Zane in a group home. So how things work in the group home here is they're a very much sought after and needed social situation here. It can take up to a decade to get in a group living home, into a group home, and when a spot comes up, that's where the individual goes, regardless of how they might fit into that home. So Zane was living with 4 housemates in a group living situation, as was mentioned, with about 2 to 3 staff. Initially, he was quiet and withdrawn, and that lasted for about a month. However, after a month, the staff started to notice that Zane was biting his wrist. And as you might remember from the previous slide, this is one of his self-injurious behaviors that he engages in when he is agitated. After 2 months, he started swiping at his peers, he started yelling, and he was throwing his food and drink. So there started to be quite a bit of agitation, especially around meal times. And to add on to this increased agitation that he was experiencing, he was starting to pace at night. So he's agitated during the day, and he's not getting a good sleep, which is just compounding these problems. Staff and his mother were at a loss and decided to take him to a doctor who hadn't actually seen him in years. So these presenting behaviors, the physician that he had seen, he wasn't aware if this was his baseline, that this was not his baseline, and it was actually an escalation of his behaviors. So the solution was that risperidone was increased, so he was taking it now at an increased dose at night, and then a daily dose was added as well. After this intervention, Zane's agitation, his pacing, and his challenging behaviors increased. He started slapping his face on the left side, and this was hard enough to leave visible bruising. And as you will note, this is actually new behavior for him. A staff meeting was held, and someone suggested a dental appointment. The manager was quick and made an urgent referral to a dentist, and he went 2 days later. So as you can see, there's multiple variables that have to be taken into account for why Zane's increased agitation is happening. So again, just like Dr. Boyd did in the previous example, we're going to go through a biopsychosocial model on why he's having this yelling, pacing, social injurious behavior, throwing, and hitting. We're going to go through the 4 Ps as well to try to help clear out some of these complicated variables. So from a predisposing biological perspective, he has Fragile X syndrome, as we spoke to. And this comes with it a whole slew of additional medical conditions that need to be considered, especially in the face of increased agitation. He has ADHD, and some of his agitation, combined with his ADHD, actually made for quite a complicated picture.
So with Fragile X syndrome, we do know something about males and their cognitive profile. Often they will have autism spectrum disorder traits, though they may be different in many ways as well. So in this case, he had an intellectual disability and very impaired verbal communication. Socially, we have a family who cared a great deal about him, but the mother was overwhelmed at the time that the father left and the younger sister was born. And the stress certainly became crisis proportions when he transitioned from school, where things were predictable, and he transitioned into something that was less predictable and perhaps not quite tailored to his particular needs. Okay, so also I'm sure many of you figured out that when he started swiping at the dinner table and slapping his face, it became clear that he had some dental issues going on. So they did take him for a dental evaluation, and the other perpetuating variable or precipitating variable was very disturbed sleep. So pain related to the dental issues and sleep disturbance.
And as you can likely appreciate, and from a psychological perspective, as a precipitating, he had an incredible amount of frustration in communicating how he was feeling and the amount of pain that he was experiencing.
Social precipitating variables were separating from his family with whom he lived all his life and all the adjustments that went along with a new setting.
From a biological perspective, in terms of the perpetuating factors, he was initially given the wrong treatment. And in saying the wrong treatment, when these behaviors and increased agitation started happening, his mother and his staff decided to take him to a pediatrician, or sorry, a physician who actually hadn't seen him for quite a long time. So not knowing his baseline and not knowing that this was quite an increase from his baseline quite suddenly, increase in antipsychotic medication was initiated in hopes that this would help calm the behavior. That, however, had its side effects. As you saw from the previous, in the narrative, he became increasingly restless after the increase in risperidone was initiated. So he was experiencing what we call akathisia. And along with the wrong treatment, as we know, this is a dental cause. It was an abscess that was bothering him. So he wasn't given antibiotics to help with that abscess. He wasn't given any pain medication, Tylenol, whatever was appropriate to help moderate those pains that he was having from this biological variable.
And I must say I'm thankful for the abscess tooth that I had, because I recognized the pain, the agitation, and it was only my dentist who could help with that. Psychologically, certainly his communication impairments compounded the distress.
And I alluded to this a little bit before in terms of, for the perpetuating social factor, he was both under and overstimulated. I explained both the understimulation from transitioning from a structured day at school to being at the home, and then he's got the overstimulation of being in the home, but now the overstimulation of experiencing quite a bit of pain and how that's fitting into his world.
So we have biopsychosocial predisposing, precipitating variables, perpetuating variables, things that kept the problems going, but fortunately we also have protective variables. He was in generally good health. When they went through the Health Watch guidelines for Fragile X syndrome, he did not have some of the other problems that can go along with it.
From a psychological perspective, as a protective factor, he truly wanted to communicate. Although we might view some of the ways that he was choosing to communicate as maladaptive, I would beg to argue that point, as he was trying the best way he could to get attention, to draw attention to what was causing him pain and what was causing him a marked amount of distress.
And also he had a circle of social supports that included a family who cared, staff who wanted to get to know him, healthcare providers, and dentists, and they determined that in an ongoing way, a proactive way, they were going to monitor for some of these problems. So the result was that he had his cavities and abscess teeth taken care of. He received the proper treatment with antibiotics, pain management, and in his case, dental extraction. The slapping of the face and the swiping during meals stopped. Risperidone was reduced to the baseline dose, and consideration was given to other medications that may be more suitable for him at this stage. Care providers determined to improve his communication, made a referral to speech-language behavior consultation, and monitored his mental and physical health. 2 websites are provided here. The Surrey Place website from Ontario with internationally used guidelines for the healthcare of people with developmental disability and dual diagnosis, and also others that are produced in the States. So we commend those to you. So the BioPsychoSocial Grid is meant to give us more clarity, a more holistic approach that will lead to an understanding and to a plan. And as healthcare providers and developmental service providers, we can rest assured that it all doesn't rest on our shoulders. We can do this in a collaborative way with the person at the center. Now, as I mentioned, the Bethesda that I work at in Ontario has a music therapist and a creative director of Momentum Choir and Spotlight Drama. We have produced a video for you, and after that we will have discussion, and then we will have one more video as you all leave and head off to either go to bed or start your day if you're across the ocean. So we're now going to present to you the BioPsychoSocial Wrap Around.
Wrap your mind around hard times. Wrap together with this rhyme. When times get tough, behaviors erupt. Stress runs high. You're gonna fight or fly. What you gonna do? What you gonna do? What you gonna do when stress hits you? What you gonna do? What you gonna do? What you gonna do when stress hits you? Ask why. Ask why? Because it's a biopsychosocial wraparound. Because it's a biopsychosocial wraparound. Why the stress? Why the strain? Why now and why again? The body, the mind, the setting. What can we find? The biopsychosocial wraparound. Because it's the biopsychosocial wraparound. Ask what? What? Ask what? Ask what's up with the body. Head to toe, let's go. Is it a headache, seizure, teeth and gums? Hearing, breathing, need some terms? Heart rate, vision, abdomen. Number 1, number 2, joints and limb. Ask how. Ask how. Ask how's the person doing right now? Scared, confused, overwhelmed, angry, grieved, cannot tell, oppressed, depressed, or abused. Let's walk in their shoes. Ask how. How can they know we're with them somehow? Because it's a biopsychosocial wraparound. Because it's a biopsychosocial wraparound. Ask who? Ask who? What's stressing, pressing, or alarming? Expectant, rejecting, or disarming? Is it boredom? Explore them. Find reasons, better seasons. Because it's a biopsychosocial wraparound. 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 Because it's a biopsychosocial wraparound.
So we realize that we can't do it all in a very short time, but we hope that last video helps you to get the picture. And we have created a curriculum of caring for people with developmental disabilities. It's found on the website that's listed right here. All you need to go to is communicatecare.machealth.ca, and we have some educational videos and some music videos in particular that we hope you might be able to use either in your practice, your teaching, or maybe even for your entertainment. So with that, we'd like to open it up for comment or discussion. And then we have one final video to show you when we're done.
All right, so far, only really have one question. Question is, can this outline be used for persons with dementia, with or without IDD?
I would say definitely. In fact, this BioPsychoSocial Grid encompasses my psychiatry residency program. So with someone with dementia, for example, who's presenting in a complex way, then it's very helpful to know something about their biological predisposing variables, their psychosocial, well, really their personalities and what they've been through in their lives. And if they're presenting in a complex or distressed way, what got it started? What precipitated the problem? And so you would want to look at things like pain or medications. Psychologically, are they experiencing losses or confusion? And maybe even psychosis or some of the neuropsychiatric problems associated with dementia. And socially, what about the supports? Have things changed? Do they need more? And perpetuating variables, again, so often medications or medical problems can keep the problems going. Things like constipation, urinary tract infections. And again, psychologically, if people are feeling kind of lost and confused about things, they really need their environment, the people around them, to be able to respond appropriately, supportively, and it will be changing over time with dementia. And protective variables, what can we tap into that will help them to have a better quality of life? So definitely it applies, I would say, to all of us, actually, which is why we started off the presentation with the BlackBerry challenging behavior.
Great, thank you. Next question is, have you applied this model to any areas of the law?
Well, that's a very good question. I think it's a model for understanding people. And as people interface with the law, we want to get to know them holistically. What happened? Why are they in the dilemma that they're in? How can we help them through it? How can we understand why they're having some of the problems that we're having? And always looking at the protective variables as well. So I would say whenever we're kind of baffled by a presentation or there's too much information, you can actually down or upload or create your own BioPsychoSocial Grid so that you can start to plot some of this information out. And I would say, just let me see if I can quickly go back without causing difficulties, then the whole idea is to come up with an understanding of why they're presenting the way they are, and what good is an understanding without a plan. And for most people, whether it's criminal justice system, healthcare, developmental disability or not, usually there's more than one thing that can be done to help people along.
Great. So our next question is, how do you identify the sensory issues that an individual may have and address those?
How do you identify them? I would say often it just starts with a behavior. Watching someone's affect, watching their face, watching what they're actually doing when something is going on around them. So if they're covering their ears, there's an indication that perhaps there are sensitivities to sound. Touch, people whipping off their clothing or their shoes because of tactile sensitivity, tactile defensiveness, people not liking to be touched in particular ways or liking to be touched in others. People who rock, for example, may have some proprioceptive issues. Often it's so helpful to get an occupational therapist to come in. There are sensory checklists that are available. Amanda, sitting beside me here, has worked with an individual with autism who has many sensory issues, and I think she would have something to offer about that.
I think the important thing to also remember is that it's not always like a hypersensitivity. There's also sensory seeking. So like Dr. Boyd was mentioning, the rocking could be that seeking of the proprioception. The young individual that I worked with, she would jump a lot, or she would like to be cocooned in heavy blankets. So it's not, so there is the sensitivity. She didn't like direct eye contact. She didn't like loud noises because she was hypersensitive in those senses. very, very sensitive to smells, like never wore perfume, tried to have scent-free shampoo. Those are all small things that we do in our daily lives that we hardly think of, that can make monstrous, that can have monstrous ramifications for an individual with sensory issues. And that being said, it's a really effective practice to actually think about it before you have a patient in your office or before you see a patient. So that might actually be a little bit more work, with a therapeutic relationship that you can establish with a patient when you're considering those things can be amazing. So it might be turning off music in your office if you have a patient who has some hypersensitivities to loud noises. It can be implementing a scent-free policy in your office if there's hypersensitivity to smells. And this may seem like it's excessive, but it can make a huge difference in the life of that person. And then there's not so much of a concern of pinpointing the exact sensitivities for every patient. It's important to do for the well-being of that patient overall, but to make a really great office setting and a therapeutic relationship can be very important.
I'm just going to add that Amanda co-produced on our Curriculum of Caring website, Meet Grace, who's the person with autism, Meet Grace, Meet Needs, and talks about some of these issues.
Great. And if you like, you could post the link to that to our chat box so our viewers can visit that if they like. So our next question is, the BioPsychoSocial Grid seems a comprehensive way to understand challenging behavior. Since you have been using this model, have there been any problems that cannot be explained or helped by using this grid, e.g. spiritual or other issues? And if so, would those be beyond the medical profession to deal with?
Yeah, one of the premises is people are complicated. They're almost, people are unfathomable when it comes to their spiritual well-being. I put spiritual lives under psychological, and it also is influenced by the social. And so, no, I don't believe we can explain people totally. And the grid idea helps us to get hopefully enough pixels, enough information that we can get a clear enough picture to be able to understand the behavior and try a few things. Sometimes you're hypothesis testing. As a psychiatrist, I may not always have a clear understanding of what's going on, but I want to make sure that I'm doing no harm by treating things, for example, with psychotropic medications that really have other underlying reasons for them. And also, as a psychiatrist, I don't want to miss treatable conditions that actually I could help with appropriate psychotropic medications. So the grid formula is to give you hopefully enough information, and you will have to gather collateral information and talk or engage with the person as much as possible, and hopefully even over time until you get enough of a picture that you can do some things and see if they help. I would say our work in developmental disabilities involves usually longer-term relationships. There aren't always quick fixes. In fact, seldom are there quick fixes. It's really committing to walking with people, working with them, and seeing if we can lend some ideas and treatments that may make things better.
Thank you. So our next question is, pain is included as a psychological factor. Can pain also be a predisposing variable or biological, as in the case of chronic pain, for example, in rheumatoid arthritis?
So we're both going to offer a comment. First of all, the grid doesn't work in real life because everything blurs together. It's just a way of getting us to think about things and not miss them. So pain is biological, psychological, and has a lot to do with the things that we do about it. So I would say it's quite a blend of things.
And you can also see from the second example that we gave, these things can show up in multiple areas. So I think communication can be a psychological factor, but you can also be a social factor. So there isn't any hard and fast reasoning for pain always have to be a biological or psychological component. It really is looking at the patient holistically, and is pain more of a biological component and a side component, or is it a psychological? And that's when I think the question is more easily answered.
And definitely it can be a predisposing variable that waxes and wanes over time, and sometimes our treatments can help and sometimes not so much. I hope that answers that question. That was also a very good one.
I think it did. I liked it. And if it didn't, they can restate their question or clarify it. So our next question, and as for now, it's our last one, unless anyone adds another one that they're thinking of, is when you have clients who are nonverbal, how do you find out more about these individuals when it is hard to get information from the family?
What a good question. That's what daunted me the most when I started this job nearly 20 years ago. And first of all, you realize we have much more in common as people than we are different. And so there's a lot you can read from someone's demeanor, from their behavioral communications, and from people who know them well. It's also true that more investigations are warranted, obviously not doing undue, intrusive or unnecessary interventions, but more lab work, more ultrasounds of the abdomen to make sure we're ruling out things that might be problematic or ruling out constipation. Those things are all warranted. So people who aren't verbal, there are people who really can give us a lot of guidance with regard to how to relate to them better, but it certainly is doable. It's extremely rewarding. And I guess the whole premise of this presentation is we can do it if we work collaboratively and in a committed, longitudinal way.
I think also, like Dr. Boyd said, always engaging the patient first and always getting as much information as you can from them. But in my experience as well, the caregiver is a bottomless amount of information. And usually they can tell you when someone's getting agitated just by how maybe their eyebrow is raising, or, I know something's wrong because of X behavior, or this, this is different. So, using the whole support network to gather information is important. Always engaging the patient first, always getting what you can. And specifically as a resident and as a trainee, some of the times it's not that much different than we do in other psychiatric consultations. We do a mental status exam on anyone, which we should do a mental status exam on anyone we come into contact with, and that is a lot of the time gathering information that is nonverbal in nature. So cooperativeness, behavior, eye contact, things like that. So, and that information can all be gathered from a patient who is nonverbal.
And for our colleagues there who said they wanted to learn about interdisciplinary practice, that is the best way, the standard of practice for people who present with complex, challenging behaviors, inter or multidisciplinary care. So we need our colleagues to be able to understand things more fulsomely. If there are other questions or comments, that's fine. We also have another video we'd very much like to share with you and invite you to go on the website. I'm just going to highlight Dr. Liz Greer, a family doc in Kingston, Ontario, who has provided a video, co-produced a video on adapted physical exam for people with developmental disabilities. You may find that in your practice and teaching as well. That's on the Communicate Care website, and it's on the it's in the last section that is under expert advice.
Great.
Mike, any other comments?
We do have another comment. I'm trying to think of how to phrase this. I think it's a good question. So say you have a patient that comes in and you suspect that they've experienced a trauma, but they might not grasp the severity of the trauma. Would you think to try to explain what's happened to them, or do you think that that would do more harm than good?
Oh, I'd look at it on a very individualized basis. I think one of the most sobering things we're recognizing is how prevalent trauma is, and abuse, and teasing, and bullying, and neglect. And I think we really need to have our antenna up for that. We need to be empathic. We need to learn as much about the person and where they're at in their journey, and then respond in a very person-centered way. And I know there are people who have a great deal of expertise with that. And very often, if I flag that that has been the case, I invite the person to talk to us or communicate with us. But we also offer options of people who are very good at dealing with trauma. And then I think giving people the choice whether they proceed with that or try something else. I always say, though, keep them safe. Keep them safe. Make sure that we're minimizing risk of further abuse and traumatization. Build trusting relationships and rapport. And I think that is a very healing and therapeutic measure.
Very well stated. I agree. Our next question is, as a dentist who works with IDD or patients with IDD, I often work intimately with patients and discover different tricks or behavior management techniques unique to each patient. How do I communicate this with other providers and get their input as well? Often they live in group homes with frequently changing home care.
Right. Sometimes just letting people know that you're open to their feedback about things. I don't know, perhaps you already have developed an information sheet or a questionnaire that you could receive from them. It's really opening the door to a partnership of how to make this successful. And also, just like we were describing, having relationships with your clientele, and I think that could be extremely important as well. And I am so glad you're doing what you're doing. It's vitally important. And the scenario that we gave of 2 weeks, or I think a couple of days or a couple of weeks before they got their dental care, I had a fellow with autism in his 50s who waited 4 months. 4 months on pain medications that made him constipated and antibiotics and in horrible pain before he had his dental care done. So thank you for doing what you do and the openness to make this really a successful experience. Some of our guys end up getting under general anesthetic, and I'd love to hear your comment, but I think that's often very helpful for caregivers as well, for those who have been traumatized or just can't be talked through some of the procedures that are going to be happening. Books Without Words is also developed out of the UK and very helpful.
Okay, well, we're very happy with how the grand rounds have been going so far, and we hope that they keep spreading so we can keep improving how the IDD community is being treated.
And sign up for a dental one as well. Is there interest then in showing the help video, which really depicts each of the professionals who we hope are tapping into our presentation? The help video is to get us to think about how we can help when people are presenting with complex, challenging behaviors. It's again a music video featuring spotlight drama, momentum choir with an original song.
So we have one last question. Why don't we ask the last question and then play the video and then call it
fine.
So the last question actually kind of piggybacks on the question about the trauma. So the question is, what are the implications of adverse childhood experiences in the IDD population, and what role does trauma-informed care play when we care for individuals with IDD?
Mm-hmm. Well, it's certainly come to everybody's awareness that it happens. Trauma-informed care training is certainly happening here in Ontario, and I think it must be part and parcel. As we look for medical problems, so we must have our antenna up for some of these traumatic experiences. And it doesn't, I would say, just have to be physical, sexual abuse. It can also be just losses and isolation. And so trauma-informed care, most definitely. I think many people who are presenting with alarm-type behaviors, aggression, defensiveness, self-injury, suicidal behaviors, maybe trauma is at the root. So thank you for bringing that to light. It does get depicted also in our help video. So the help video, if you go on the same Surrey Place website, you'll be able to see the help acronym developed by a dual diagnosis specialist from the UK, Elspeth Bradley, one of my mentors. She joined us for a focus group of people with developmental disabilities who talked about their experience and co-produced this video. You'll also see Dr. Amanda Ritzman, who is depicted as one of the psychiatrists, being quite sensitive at the very end of the video. So with that, we'll play it. We will stay on the line, Mike, if anyone does just want to offer any final comments or thoughts, but then we'll leave you to be the moderator and tell us when we have to quit.
Sure thing.
Okay, so this is the help video. We hope the song catches on too. So we're working on a companion guide to go with that. If you check our website in a couple of months, you'll see a little bit more surrounding that video. But there's also a link to the Surrey Place Center website in the HELP acronym.
So we don't have any additional questions.
Great.
So at this time, I think we can say, oh, wait, something might have just popped up. Nope, just a comment. So I think at this time we can say from New York, I hope everyone has a good evening or morning or wherever it is, wherever you're joining us from. Thank you very much, both of our presenters. You have a wonderful presentation. To everyone who's still on, I'm going to post one more time in the chat box the link to the survey. If you could please just take 5 minutes to fill that out. Give us your feedback. Let us know what your thoughts are about tonight's presentation. And with that, that's all I have.
Thank you. It was great hanging out with you.
Thank you.
Great. You too. I appreciate it. And I hope to see you at the AADMD conference.
Us too.
All right. Have a good night.
Bye now.